Okay. So while other people are trickling on, I'm going to give a few announcements. Okay, so my name is Melanie Nordstrom, and I am like the program manager for the Pilot Award program. It's called the Investigator Development Corps, but to you guys, you probably think of it as the Pilot Award program. Um, so it's been a while since we've met over Zoom or in person, and we've had I think two new cohorts of pilot awardees have come on, and several new people with mini grants, also called community grants. And so, but I should also thank you guys also for providing timely progress reporting, and we're so sorry that our funder is requesting that at such high frequency. So we are now up to four cohorts in the pilot award program, and then the applications for the fifth cohort are October 1, and I sent the RFA out to all of you guys last week. And if you could forward that to your friends and colleagues, that would be great. Anyone you know who thinks that you think might want to apply, that it would be great to see applications. What else do I want to say? I think before we start, I want to give you a little bit of information about sort of why we're doing this seminar series today and sort of what we hope that you will get out of it. And then I'll introduce Doriane very briefly and she can start. Okay. So a lot of you guys are new to the Pilot Award program and to the Chicago Chronic Condition Equity Network. I should also say that our director for the Pilot Award program, the IDC, is here, Brad. He's on this call if you have not yet met him. And so, okay, so one of the goals of this Pilot Award program is to provide you career training opportunities and career development and mentorship and things of that nature. So we wanted to sort of try out doing a seminar series where you met some of the more established health disparities researchers that are part of C3EN, which is how you pronounce our acronym. And so we're starting with Doriane Miller because she is one of the co-directors of our Community Engagement Corps. And so there are across all these centers, the P50 centers that are across the nation, there's also a coordinating center that has their own seminar series, which is very, how do I want to say? It's like, it's very prepared. There's like slides, they record it, they post it online. And so I will put a link for that in the chat so that you can check those out because you might not be on their mailing list yet. So you may not, so you can go back and look through there and see if there's anything that you're interested in viewing or seeing in the future, making time to see or see what's coming up. So there is that. And I kind of wanted, well, the Investigator Development Corps wanted to do a slightly different format of seminars because you go to a lot of those seminars where somebody presents for 45 minutes and then, and there's a Q&A on a highly specific topic. So the idea behind this seminar series, and we're just trying it out, so please complete the evaluation survey at the end so that we can get your feedback, is that we would have an established health disparities researchers come in and talk to you and give you a very brief overview of their research and the course that their career has taken. And then you guys could ask questions about things that you might currently be struggling with, such as like maybe relationships with community partners or how to pivot from a pilot award to an R01 or establishing new career relationships or establishing, I know Doriane started out in California and then moved to the Midwest, and how did she establish new partnerships and relationships in this city? So as you're listening to her talk, try to think about things where her journey intersects with your journey and what you might, what questions you might want to ask Doriane. This would be wonderful if it was in person. I'm not sure 100% if it's going to work over Zoom, but we're going to try it out. We'll do our best. And but before Doriane starts, let me make sure that you know several key people that are on this call. And thank you so much, all of you, for attending so far. So as I said, Brad, do you want to say hi really quick?
Hello, everyone. Thanks, Doriane, for doing this. It's great.
Yes, Brad is one of our co-directors. He's at Rush. And Arshia, do you want to say hi?
Yes, hi everyone. I'm at the University of Chicago. I'm a primary care doc, general internist, and health services researcher. And thank you, Doriane, for coming today.
Christy, can you go ahead and say hi?
Sure. Good afternoon, everyone. My name is Christy Edwards. I am the program manager for the Community-Based Research Network. Many of you I have had conversations with, many of you I have not, but I'm really looking forward to today's discussion. Doriane, thank you so much. I am here to learn from you, the master, but thank you for everyone. Yeah, welcome. Thank you.
Okay. And then our guest of honor is Doriane Miller, and she's at University of Chicago, and her role in C3EN is as a community engagement co-director of that core, which is hosting the town halls that you may have heard about and gotten emails about. And then she's also part of the Institute for Translational Medicine, and she's had many roles throughout her career, and she's worked on a really broad variety of chronic conditions. And yeah, and she's going to tell us a little bit about that today. All right. Oh, and she's only going to speak for about like 15, 20 minutes. Maybe put some questions in the chat, and then the rest of the time is going to be like open discussion. All right. Thanks. Take it away, Doriane.
Great. Thanks so much, Melanie. And really looking forward to getting questions in the chat. And you gave me 15 or 20 minutes, and my career goes back to the late 80s. So hopefully I can compress things into that period of time. But I'll stick to the work that I have done and how I came to become involved in community engagement work. In the early part of my career, and this is going back to when I was doing a fellowship at the University of California, San Francisco, through San Francisco General Hospital. It was in essentially the midst of the crack cocaine epidemic. And I was caring for patients in one of the community health centers in San Francisco in a neighborhood called Baby Hunters Point, which had fairly high rates of not only, unfortunately, crack cocaine use, but 1 out of 3 children that were living in this neighborhood were being raised by somebody other than their biological parents. The reason being that the parents were either not available because of substance use disorder, incarceration, or just kind of off the grid. As I started seeing these patients, I started asking the questions, what's going on in the community and why is it that I'm starting to see this? And had conversations not only with my patients, but also with other physicians and nurses, healthcare providers that worked through the county hospital system in the city of San Francisco. And they said, really interesting question, let's start doing some inquiries. Had the opportunity to do some inquiries with a community-based organization that was involved in family stabilization, along with making referrals for substance use disorder, called the Baby Hunters Point Foundation, and found that it was indeed crack cocaine that was causing this particular issue in the community. And then asked the question, well, I'm seeing the grandparents, I'm a general internist by training, and they're coming into clinic in their early to mid 60s with 3 and 4-year-olds in tow for their clinic appointments. What are their needs, who's supporting them, et cetera. And so as a result of that, in partnership with a social worker and a nurse, we started an organization called Grandparents Who Care. which was it was the second grandparent support group that was started in the United States as a result of the response to not just the crack cocaine epidemic, but also grandparents raising their grandchildren. The first one was started down in Orange County, California. In addition to recognizing this and starting this as a grassroots project, we also received some attention from UC Berkeley School of Public Health, and specifically a gerontologist there who had done a lot of work in the area of community engagement. You may be familiar with her name. Her name is Meredith Minkler. And Meredith was also looking at this issue, including issues around depression in grandparents who are raising their grandchildren. And so we formed a partnership in this particular program. So we had grandparent support groups that were going on through San Francisco General Hospital and a number of the community health centers that surrounded the hospital, but also working with Meredith at this point. And I was a fellow at the time, a general medicine clinical epidemiology fellow. We started working on ways in which we could both document some of the issues that were involved, but also working with city leaders on how we could provide support for the grandparents raising their grandchildren. The families that were primarily affected by this in San Francisco were families that were African American or families that were Latinx living in the Mission District, and then a smaller group of families that had migrated to the Bay Area that were of Samoan and Tongan descent. And so those were the kinds of groups that we set up. And we set up those groups specifically in those racial and ethnic groups and brought people together. After doing this project for about, let's say a little less than a year, we started noticing that the grandparents were actually supporting one another and providing one another with resources more so than we were as a doc and a nurse and a social worker. And so I received some funding through the City and County of San Francisco to train grandparents to become peer support leaders. And so we developed a program that was a peer and professional partnership and started to expand the support groups that were there for the grandparents raising their grandchildren. Fast forward a little bit more, the Edgewood Center for Children and Families, which was a child welfare organization in San Francisco that was started during the California Gold Rush in 1849, originally as an orphanage, but then evolved their services. They were looking for a way that they could implement primary prevention programs for kids that were coming to them in some of their residential treatment programs. And they had a program that was established in schools for primary prevention, but they also wanted to start working with families. And so after several years, we ended up merging the program with Edgewood Center for Children and Families and developed a program called Kinship Care. The model for kinship care within the state of California ended up spreading from the City and County of San Francisco to 26 other counties within the state of California as a result of the work that we did with this program, in addition to generating a few peer-reviewed publications around some of the challenges that were taking place as a result of the crack cocaine epidemic. Founded this program in 1989, and believe it or not, it's still going today through Edgewood Center for Children and Families, in addition to the programs that are taking place in other counties within the state of California. So that's how I got my toe into the water with this, but it actually, I think in many ways grew quite organically from my interest in figuring out how I could do a better job of serving the patients in front of me, and knowing that by serving them, it didn't necessarily have to do with treatment of their high blood pressure or their diabetes, because they weren't coming to their doctor's appointments in the first place, or they were doing so very sporadically because they had these other responsibilities of caring for grandchildren, nieces and nephews, et cetera. And so being able to provide this level of support using, Teresa, I'm going to call you out on this because we used a social service intervention model around this of operational support, informational support, and practical support in the implementation of this particular support group, that we were able to provide them with services. and in addition to looking at it from more of a community, through a community engaged lens. The other thing that I think that just in terms of from a formative perspective for me that was important was that it was at a time in which there was growing advocacy taking place both in the space of HIV as well as breast cancer. And so as opposed to the development of programs that were taking place in parallel with organizations like ACT UP and others, people working in the breast cancer advocacy space, that there seemed to be much more movement and convergence of having people who with lived experience to become involved in the work that's being designed. I think that ACT UP and the development of the Ryan White Act is certainly a very good example of that, just in terms of how that evolved within that space. Things like Susan Komen, Breast Cancer Research Foundation, and others, another a way in which there was a convergence of people who were working in the advocacy space. And as opposed to having them work in parallel, actually having those organizations to work together. I'll jump ahead a little bit because my career took a few other twists and turns, including a stint in working in philanthropy and helping to promote that kind of work in terms of program design and development. But the last program that I did in this space was a program called New Health Partnerships, Improving Care by Engaging Patients. This was a quality improvement program that was funded through the California Healthcare Foundation and the Robert Wood Johnson Foundation, in which we looked at the chronic care model and highlighted the self-management support piece of this and said, what can be done within healthcare delivery systems in order to improve self-management support, but to do so through a patient lens. And so through these quality improvement teams that met together over the course of several months, and we had several iterations of this of organizations around the country, we had people with lived experience at the table with docs and nurses and administrators co-designing care in order to improve the delivery of care, in order to improve health delivery for a number of chronic conditions. And so diabetes was part of it, depression was part of it, hypertension was part of it, and a number of other health conditions. And we had about, if I remember correctly, about 30 teams around the country that participated in this space. And so that's a little bit of the short and sweet of how I came to both start a career in terms of community engagement, but also helped to grow that over time in terms of the work that I'm doing today. So, Melanie, you think that's enough? Should I stop there?
Yeah, let's see where the conversation takes us.
Okay.
I am a little bit, there was like so many interesting things that you said. I have a question about, did that project, was it a funded pilot award project in any way? Did you guys have like research funding for it, either you or your collaborator? And then did you guys ever pivot that out into an R01 or what? So yeah, talk a little bit about the funding that was behind that work.
Sure. So the funding that was behind the first project with the grandparents program had private philanthropic funding throughout, save for the one city grant that I had in order to train grandparents to become group facilitators. And actually, let me see. So in 1993, I received an award from the Robert Wood Johnson Foundation for the work that I did with that project. For those of you who are familiar with their Culture of Health Leaders Awards, this was a predecessor for this award. It was called the Community Health Leadership Award. And so I received some grant funding through the Robert Wood Johnson Foundation in order to help to promote the work and to do development with it over a 3-year period. But as we started to think about how this work might be sustained, it was important to have a permanent home for it because it was me and the nurse that I worked with and a social worker, and it wasn't really embedded in an academic context. So that's one of the reasons why we ended up merging with Edgewood Center for Children and Families, because they had a very strong evaluation department as well as a delivery department to meld those things together. For the New Health Partnerships Program, which was originally called Quality Allies, that was funded through the Robert Wood Johnson Foundation and the California Healthcare Foundation. Did not receive any NIH funding for that R01 funding, but essentially in the way that the program was set up, it was essentially the equivalent of that, with the same types of expectations. And so that's the way that the funding worked out for that particular program.
That is so interesting that please feel free to jump in with questions. Anyone else? Let me make sure that I can see if somebody's raising their hand. Okay. I think it's very interesting that, you know, hindsight's 2020. So I wonder if it was really like this at the time, or if it just seems like this, like in retrospect. But it sounds like when you were very strategic in thinking about which organization you were going to partner with for the sustainability. And did you have any guidance or mentorship on that, or it just sort of seemed self-evident after being in that field for so long, like what kinds of things that the program was going to need moving forward?
For the grandparents program, we worked with a consultant from the Kaiser Family Foundation that provided us with feedback and assistance on how we might be able to move the project forward. We actually did apply for federal funding with the grandparents program at one point through the National Institutes on Aging, but the field of community engaged research and community engaged interventions, we were ahead of the curve. And so what we wanted to do, they weren't there. And so we did not get funding through NIA for the project. But we found that through the philanthropic funding, because there was a bit more latitude in terms of being a bit more experimental around implementation of this work, that we were able to maintain funding in that way. And so that we strategic in that position. The Community Health Leadership Award that I received through Robert Wood Johnson gave me 3 years of monies that I was able to put into the program to push us towards the partnership that we were eventually able to meld with Edgewood Center for Children and Families. Christy, you've got your hand up.
Yes, so earlier today I had 2 meetings with some community members in the Austin community, and both meetings the topic of researchers coming in and basically leaving once the funding is gone came up, because of course there's this mistrust. So I was just curious what advice you might have for researchers who are interested in participating or partnering with community organizations.
Thanks, Christy. One of the things that we did with both the grandparents program as well as New Health Partnerships, Improving Care by Engaging Patients, was to have patients and community members on the advisory boards. Because being able to, when I talked about co-creation, it wasn't done in parallel, it was done in conjunction with one another. And they were the people that were actually incredibly important for program design, program implementation, and supportive in terms of being advocates for helping the program to sustain itself. I've since being at the University of Chicago, I've had the opportunity to work with Dr. Stacy Lindow over the years on a program that she started. It was originally called the Southside Health and Vitality Studies, and then later evolved into MAPS Core, Meaningful and Productive Science and Service to the Community. And the model of incorporation of community members into the process has been central to that program from the very beginning. And one of the things that I think is absolutely critical, and this is something that was picked up later by the Patient-Centered Outcomes Research Institute, is the types of principles around patient-centered research and incorporation of patients and community members into the planning, implementation, and dissemination of results, to make sure that there are guidelines for doing so. In addition to that, and this is another resource that you may be interested in, organization that was started a little over 20 years ago called Community Campus Partnerships for Health. great resource in terms of not only principles of authentic community engagement, but as well as models for community engagement, including really practical things like if you have community members engaged, how do you provide them with compensation for the expertise that they are giving you for the projects. It's not enough just to say, you know, thank you very much and a clap or a pat on the back, but community members really do add so much to the work that takes place that it's very important to provide them with compensation in some way. And that's one of the reasons why, and I'll harken back to the grandparents program for just a moment. In setting up the peer professionally led support groups for the grandparents program, we were able to get city and county funding in San Francisco to actually pay for these peer leaders to lead the groups for the grandparents program in order to recognize their lived experience and expertise in the work they were doing for the grandparents program. And it also, after we were able to merge with Edgewood Center for Children and Families, it led to staff positions within Edgewood Center for some of these grandparents to continue the work.
Doriane, that is a perfect segue to my next question. How on earth did you guys find out that you would have support from the city? How did you get this on somebody's agenda? You know, how did you get this in front of policymakers? And then I know eventually this led to some policy changes at the state level as well. And who spearheaded that? Was it the Edgewater people? Or sorry, maybe it was Edgewood. Or was it, yeah, anyway, I'm kind of curious about sort of both aspects of that at the local and at the state level.
It actually started fairly early on with the implementation of the program at the state level, and policy changes came a bit later. But there was a minister, fairly famous minister in San Francisco, Reverend Cecil Williams at Blythe Memorial Church, who was very concerned about the issue of the crack cocaine epidemic and did a conference and did a lot of convening of people who were all over the city that were working in this space, including leaders through the Department of Public Health, leaders in social services, et cetera, and brought them together to talk about the program. We were the only ones that were part of this group that were actually had family-based interventions that were involved in this program. And so our initial funding came from a private philanthropy that came to one of our sessions and saw that we were doing this work. But having city and county leaders that were at this conference, in addition to inviting them to the support groups, we actually had at one point, we had the chief of police to come to a support group. We had the mayor of San Francisco and his wife to come to the same support group to talk to the grandparents about what they were experiencing. We had the head of social services for the city and county to come and to talk to what was happening, because the grandparents were saying, we've got police officers that are raiding our homes at 2 or 3 o'clock in the morning, looking for the parents of these grandkids, frightening us half to death, and we don't know what's going on. We are taking care of 3 and 4 kids for whom there are 4 social workers and 4 financial eligibility workers dealing with the same kids in the same family, as opposed to having something that was more centered on the family unit. And the grandparents in this case, they were really the heroes in this space in terms of saying, I'm going to go get these kids and we're going to figure out the finances and how the kids are going to be supported later. For those of you who work in the child space, we had unfortunately children that had been born to crack addicted moms that had had intrauterine strokes as a result of the mom's use of crack cocaine, and how those children were being supported was also another issue. And so a number of issues that we had to really sort through in terms of support for these families. Other questions or comments? And also, what kinds of issues are you having in terms of working with people on your projects, or working with people in the community that you might have questions about?
I can't find the raise hand, so I'm just gonna, okay, that's okay.
That's
Thanks,
fine.
Dorian. It's always so wonderful to hear from you, and you got to work with one of my heroes, Meredith Minkler, so, remember taking a course on community-based participatory research in my, then Steve and I tried to write a grant and people still didn't know what CBPR really is, and actually getting communities to pick their own health issue is not, I don't know if NIH still knows that. So it's really great to hear from your experience. I mean, I just want to second Christy's comment. I mean, every time I meet with community groups to talk about any like research ideas or partnering, I get, same two things as why does this need to be done? We already know this stuff is a problem, right? Like, why do you need more research? Because a lot of the stuff I do is, data gathering and then moving into intervention. So they're like, we already know this is a problem. Why do you need more information? And what are you going to do when you're gone? Like, we need, like, tell us what you're going to do before we sign on. And then the other thing, my community partner who I've been working with, often loves to point out that $10,000 will get us nothing. And so, right, like when I wrote my proposal, I was very cognizant of that because, Sinai also has no money. And tried to also write in some stipends for like any of their staff time that helped like get focus group participants. But still, like they keep challenging me on it, rightfully so. And so I feel like I'm, going to have to scale down some of my stuff because $10,000 just, and this is not a critique on scene or right, like it's just in life, right? Like money doesn't go as far as we can. So I guess my question is, what has your experience or others been like in order to meet your community partners halfway, scaling down some of the research or the deliverables, but then also managing that with your funder? So did you come across any of that? Does anyone else come across that? What are they doing?
So leveraging of resources that you're given in order to make sure that not only are you approaching satisfying the deliverables, but also what does it mean to the community? Being clear about expectations is something that I think is absolutely critical because research happens at the speed of trust. And if you lose trust with your community partners, then not only will you not be able to accomplish what you set out to do, but in the future, they will not want to work with you. And so being able to be honest as possible is important. I also think that to the extent that you can think about leveraging resources or bringing them in, whether they be small or large, I think that that's also incredibly important in order to be able to do that. The researchers investing in the community as opposed to paying for staff time and studying the community and how the community members would define what they would like those funds to go towards, I think is important. I've been working with a community organization out on the southwest side for a number of years and have asked them to participate on various panels internally. But I also have asked them, is there something, I can't set up a mental health clinic in your site, but is there something that I can provide to you or to your staff that you think would be of help to you as a physician? And so I will go out to fundraisers that are in the community. I will provide lectures on a particular topic with perhaps a connection to any resources that I'm familiar with as a gift. Stacy Lindow has called these things GORDs sometimes, GORDs standing for Gifts of Usable Research Data with the acronym GOURD. And if you think about the visual of gourds in a cornucopia at Thanksgiving, that's kind of the visual that goes along with that. And so being realistic about what's there, Christine's point is absolutely essential, asking the community, after you've said, this is what I can give, how do you want to use it, is very important as well. And then making sure that when you're forming these relationships, it's not an in and out. The relationship that I just described a moment ago, I've had with this community organization since 2009. This is 2024 at this point, and we still continue to work and collaborate on various things. And so it's a question of making an investment in the relationship rather than thinking about it as a discrete project by project. If you plan on doing work in this space over the long term, and Melissa, Sinai Community Institute has got just an incredible reputation in terms of work that's taken place in the community in this space and having these longitudinal relationships. When Steve Whitman was alive and doing this work, it was something that was very central to his philosophy in doing the work. And so I think that's something else, someone that we really need to take into account. Arshia, can I call on you for just a minute to talk a little bit about the work that you've done in Pilsen and diabetes and relationship building and what that's meant to you in terms of your journey?
Yeah, thank you, Doriane. Oh my goodness. I feel like I've known you for a while and I always am impressed and amazed by the work that you've done. So thank you for coming and sharing today. So yeah, so I was a Robert Wood Johnson clinical scholar actually a while ago. And that's when they had changed their training from being like pure health services research to community-based research. And so, I think that was one of the first training programs that had this new focus, and they didn't really know where it was going to go. Actually, it was at that time, at least in clinical medical research, CBPR was new, although, in public health, it's been going on for a long time. So when I joined faculty here, that's what I wanted to do because that's what I was trained in. That was the work that I did. I partnered with churches in LA to address hypertension outcomes through the health fairs that parish nurses were already having and connecting people to care. And we actually found that having a parish nurse in these health fairs was actually really beneficial because they identified so many people with uncontrolled blood pressure, which was elevated. And then we worked to get folks into care and actually found that their blood pressures improved after several months. So then when I came here, I wanted to continue working with churches because I learned so much about them in terms of the resources they provided, and they were just really essential places for many immigrant communities. And, they had health fairs, they had job programs, they had counseling, they had schools, they had volunteers, and just really very essential to many communities. And so when I came here, I actually was not a diabetes researcher. As I started having conversations, and I knew I wanted to work with Latinx populations, and I was sort of learning about the concerns of the community. I always joke, like the first few months of my job here, I was like never in my office. I was like always out in Little Village meeting people. That's when like there was no Zoom, right? You had to like go meet people in their offices. So I was meeting people and really used to snowballing, like I would meet with like an executive director of a health center, and then, they would tell me, oh, meet with this person. Okay, fine. So I would go and, set up meetings with these folks or meeting with pastors. And that's actually when I started realizing that diabetes was a major concern, but I will say actually, and I tell this story often, is that the first time I met this one pastor, actually, he had a leadership position in the archdiocese. And so he had seen a lot, and he was actually in charge of like 6 other, all the Catholic churches in Little Village and Pilsen. And he's like, yeah, we need help. First of all, like gang violence is a major issue in our community. And I was like, oh, I don't really, that's not my area of expertise. What's number 2? He's like, oh, infant mortality. We have a lot of babies dying because I'm doing their funerals. And I was like, oh my gosh, okay, that's an interesting perspective. And I unfortunately am an adult internist. I don't know much about that. I'm like, give me your number 3. He's like, diabetes. I was like, oh. And then he's like, oh, and then after that, hypertension, stroke, high cholesterol. I was like, okay, 3 through 5, I can help you with, you know? So it was a not a negotiation, but a conversation, right? Like matching my skill set to what he perceived as a big need. And that was really because a lot of folks were coming to him to learn about diabetes or their concerns about stroke or heart disease and such. And he and his other pastors didn't have training in that. So that's how it all started, actually, you know. And then I, partnered with the parish nurse who was working in one of the churches and an MSW student. And we started doing focus groups because I was like, we need to hear from the people what they want. So we did focus groups of Mexican Americans with diabetes and their family members. That's what my community members said. We have to include family members. And then we heard what they wanted and then ended up publishing it. I was like, have we really not talked to Mexican Americans with diabetes to hear what they want? So then that's where we started the church-based program based on their feedback. And really when I came back to, I was like, okay, let's design intervention. I went back to all those people that I met along my journey and I invited them to be on my community advisory board. Some people said yes, some people were too busy, but and they're the core people who helped me actually with my career development award. And we put together an application. I got letters from them. And when I think even before we got the money, we started working on the design of the intervention. So that was the story there, the start of it.
Thanks, Harshia. As you can see, the question of being able to peel back the layers of the onion to make sure that you're having the conversation with people around their specific needs, and also the point that Harshia made just a moment ago, going to people where they are rather than expecting them to come to you. The way that I started getting involved with the grandparent stuff was on one summer afternoon in which this woman in her early 60s came to clinic with her granddaughter in tow. Granddaughter was maybe like 3 years old. And I was just making general conversation, oh, I see your granddaughter is visiting with, it was in August too, was visiting with you for the summer. And she said, no, my granddaughter lives with me. And that's where the questions got started. And then starting to expand the circle of who else knew something about the issue and also how the issue evolved. And the point that Christy is putting in the chat right now, partner with community before your research project begins, is another opportunity for trust in terms of building those relationships, both in the short term and in the long term. For the MAPS core program that I mentioned just a moment ago, the relationships were facilitated by our Office of Community Affairs at University of Chicago Medicine. But when I say facilitation, it was a warm introduction. It was not a continual thread of having them to maintain those relationships. And so this kind of work is retail, not wholesale. You cannot count on someone else to do this work for you. And one of the things when I'm talking to my medical students and residents about this is that I look at some of the principles that are in a work, if any of you are familiar with the work of Brian Stevenson, who runs the Equal Justice Institute in Montgomery, Alabama. You need to get close to the issues. You need to remain hopeful. You need to engage the people that are involved in it. Because again, it's really a way in which you can make not only the information that you're seeking to gain and to make improvements more meaningful, but you're also learning a lot from the people that are engaged in communities and in the work itself. So we learned something in the Chicago Chronic Conditions Equity Network during our town halls that helped to change how we're doing our work now. In that, as opposed to, in addition to, I should say, focusing on cardiometabolic health, we included mental health. And the reason why? Because we went into the town halls and asked people, what's going on in your communities that you're concerned about in the area of health? Communities thought about this in a much broader sense than our original intent. And what we had to do in response to that is that we went back to our funder to say, we're going to be changing our approach in this work that we're doing over a 5-year grant in order to include mental health. based on what our community partners have told us. And we submitted several grants in order to support that. And I believe, if I remember correctly, 2 out of the 3 were funded. Is that right, Melanie? Yeah.
Yep.
And and it was because of the issue of mental health and what the community was telling us. They said, you know, the reason why I'm not taking my diabetes medication or my high blood pressure medication is because I'm depressed and stressed about what's going on in my community. And so what kinds of things can you formulate in terms of research questions that start to get at some of these things that will help us in the long run? So again, iterative process, being able to engage in a relationship, being responsive to the questions that are asked, and then being able to adapt moving forward.
I have a question, Dorian.
Yeah.
I hope others don't mind me asking a question, but I guess I'd wonder how, when is it the wrong community, or like when is it not appropriate to do community partnered research? And I have in mind examples of when someone might be interested in a topic. For example, you're interested in depression in a certain group. It could be a racial group or just low socioeconomic status. And you want to do a community partner project, but now how do you go from taking such a broad issue to a specific community? So sometimes I've seen that go kind of poorly, where you might start off with kind of pretty global disparities in an outcome, and then you go to one specific church, for example, and now that becomes the community in your project. Do you have any guidance for people who want to do community research, but maybe are kind of starting in the literature rather than starting in the community?
All research starts in the literature, for better, for worse, by and large, just about all. Just in terms of how people tend to approach things, because you need to have at least a working hypothesis, and whether it be based on more prima facie type evidence of an experience that people have as clinicians, and then go back to the literature looking for data that would help to support any conjectures. I think that that's how things tend to come together, as opposed to just going out and saying, hey, we're going to start a show and this is what we're going to do, but being able to ask, to do those kinds of critical inquiries. But being good academicians as we are, we may have that first, prima facie evidence of something going on, but then we go back to the literature to see where are there gaps, what exists, what kinds of gaps need to be filled, and in terms of outstanding questions. And so I think that that's a piece of it. The other part, the first part of your question was, when do you make the decision perhaps of not doing research in the with a community partner? I guess a lot of that depends. Secondary data analysis around certain questions, I think, might be a way in which one is doing, working with established data sets around a particular issue or problem. But if you're thinking about doing any sort of intervention that's going to involve a community, and community defined very broadly, so not just a geographic community, but people who identify race, ethnicity, people with lived experience, etc. You may want to at least have some portion of your work, I'm not sure if vetted is the right word for this, but at least reviewed, and asking the question to ask if you are asking the right questions in the design of the work, because you may find something very different than what the community thinks is a critical question. And that's what we found in our town halls. And a lot of that was supported by the Healthy Chicago Equity Zones data as well. John, you had your hand up.
Hi, thank you so much for joining us and for providing some advice for us. I'm new to health equity research. I'm running a focus group on individuals with lived experience with musculoskeletal disease and pain. And some of the topics that are important to pain are just topics that are difficult to talk about in like a group setting. So I'm having a hard time getting some information like about mental health or personal finances and how to affects musculoskeletal care. But they're so important that I want to learn more. So I was wondering if you had any advice on, how to broach like, difficult topics, and if it's even possible in that kind of setting.
I think it's possible, and I think that it's possible with a little bit of advice from the people that your target audience. And so the people that are serving on an advisory board may, in some respects, reflect the audience that you're aiming towards and can give you advice on how to best connect around those questions. And it may be you can't, it's, you know, what is it? You don't talk about money and politics and religion, those three things with people. It may be, hi, I'm going to talk about at least one of those things, but I'm going to do it in a way that is in private, respectful, etc., with all of the appropriate ethical guidelines in place in terms of developing a particular protocol. And so you can depend upon people for advice, and they don't necessarily, they're not going to be your study subjects in there, but to think about some of that wisdom and common sense that will come through as you're designing your intervention.
Thank you. Thank you very
Also,
much. Yeah.
thanks. Also taking advantage of review boards. You know, you've got Brad and Arshia who have a lot of experience in this space, asking them about implementation issues. We have a community advisory review council for the Institute for Translational Medicine, and that we have people to present their work there. Thanks so much, Teresa. Glad you could join us. That is a part of the work that we have people to present. And the people who sit on that body are people who are not, you know, investigators, but they are doctors that are frontline providers in the community, nurses, social workers, police officers, ministers, people who will have a bit more of a community context on how your work might be seen by people in the community and that they can comment on it. Other questions or comments? I think we're coming up towards the end of the hour here.
I have a question, just seeing if anyone else unmuted themselves. Can you give an example, either in your own career or from somebody that you've worked closely with, of a time when a relationship went through a difficult patch, either with like a research partner or with a community organization, and sort of what was the work that you put in to rebuild that relationship or to rebuild trust? And maybe like how you sort of righted the ship or something.
Sure. Example of working with a group in the city of Chicago through Claretian Associates, which was the home organization for a grant that they had through the Local Initiative Support Corporation's New Communities program. I was organizing a community grand rounds for that community in conjunction with community, and had not realized that the community partner, we were going to do something in the arts space, and arts is a pedagogic vehicle for health education, and had not realized that the person involved actually not only had an arts background, but was an actress that had IMBD credits when you go look for them online. So it's kind of like, who knew? And the person who was involved came back and said, you shouldn't be doing this work. We should be doing this work. And we have this background, and we have an arts focus in terms of our particular work. And this is what you should be doing. And it was like, uh-oh, on my end. And thank you for telling me, because I wasn't aware of the depth that you and your organization have in this space. Let me back up a little bit and then say, how would you reframe this in order to make sure that the work that's been done in your organization is reflected in this space? And it was around domestic and intimate partner violence. And so what we ended up doing for that community grand rounds is that I wrote a monologue on related to domestic and intimate partner violence that was presented as a piece of that, in addition to having a panel discussion around it. But we also had 3 actresses who had been involved with doing the choreo prom by Enzotaki Shange, if you're familiar with For Colored Girls, to do a piece of that particular choreo poem as a part of Community Grand Rounds, because this was a group that she had been engaged with. And so it was back it up, apologize, figure out where we could have a meeting of the minds around it, because the person involved thought that I was in a space where I should not have been, but we were able to compromise and collaborate on that Community Grand Rounds. It turned out very well. We've got about 3 minutes left. Any other questions or comments?
I just posted the evaluation survey link in the chat. If you guys want to complete that, I'll also send it out via email in a few minutes.
Okay. Well, thank you so much for having me today. Hopefully, if you have other questions or things that come up around your projects, I'm going to drop my email into the chat, and you can contact me around perhaps specific questions or issues that you may have. Okay.
Thank you again, Doriane, for your time. This was so helpful and for sharing so much.
My pleasure. Take care. Thanks. Bye-bye.